GI-GU is a very complex subject when it comes to pediatrics. There are more gastrointestinal diagnoses that you ever even knew existed. But when you come to pediatrics, there are so many of them. So GI-GU, chapters 41 and 45. There are some things due this week. I know there's been some problems, and I don't know if it was in this class too, but one of the pediatric assignment exams had closed and was showing zeros. Have anybody seen that in their case studies? Or because it might just be one class, which I've already sent a help ticket on. And also I've had students do that too to get that taken care of. Diabetes will be due, you have NCLEX questions due, and then quiz 5 is on this week's material. You're going to see it on both GI and GU diagnoses in the child. The pediatric assessment project is due by Sunday. Again, anybody who doesn't think they've done it right or wants any input, send it. You can attach it because there is unlimited amount of attachments on that assignment. Because I know some students keep turning it in. So I have it open that way. So send it there, send me a message, and I'll review it. And I'll tell you if you're good or if you need to change something or add something. Because, you know, I don't want you to do poorly on this. It's 6% of your grade. This is like more than NCLEX or more than your case studies. It's a big part of your grade. So I want you to do as best as you can. So we'll start out with the PowerPoint, and then we'll be going into the Kahoots. I've reviewed the Kahoots again, looked at them, and made sure that what I'm giving you is what you need. And I've added again more pictures because I like pictures. And I think as a student, I think pictures really tell you a lot when you can't understand what I'm trying to tell you. So I like pictures, and I think they just bring brightness to the slides. So gastro and GU. So GU issues. The most common of all infections in a child is a urinary tract infection. It is because of the way that we get potty trained. It's because we don't know how to wipe ourselves, because we like to sit in bubble baths, little girls, little boys. Also because little girls like little tight, little stretchy pants because they look cute, but of course that holds the heat in. And then of course, holding your stools can be a part of this, and that creates also holding of your urine, which causes urinary tract infection. So keeping fluids going on these children are important. It's more with girls and boys, but there is a high incidence of males that they're uncircumcised, that you have a higher risk of urinary tract infections. You know, many parents don't want to pull back that foreskin because it's going to hurt them. And inside the foreskin and the penis is this, what we call cheese called schmegma. And that is like a petri dish for bacteria. So if we don't pull it down, we don't clean it, it can cause infection to go into the bladder. So when you see a child who is already potty trained and all of a sudden they're starting to be incontinent, check for urinary tract infections. You could see strong smelling urine, or you could see them, you know, wiggling a lot and holding themselves in that area, and even redness in there. And you can probably determine that's urinary tract infection. So some of the things that we need to teach our parents, especially on the younger children, is to clean front to back. As simply as that can be one of the biggest things that we can teach them what to do. And of course, washing hands. They also say in the adolescents that if they're going to be sexually active, adolescents who are getting more urinary tract infections, we need to teach them to urinate as soon as after intercourse as possible. And that has been shown to decrease the amount of urinary tract infections. So we get a urinary tract infection, we have all the signs. You don't necessarily need a fever. Okay, it's an infection that may or may not have a fever, but you're going to see that burning and the hurt and frequency, and it's uncomfortable. So we know that we need to do a urine on these children. Now, when we do a urine on an infant, the best specimen is a catheterized specimen, because then you only have to do it once. And then we'll know that the antibiotic that we're giving that child is correct. If we just put a bag on a girl or a boy, we might be getting some of the surface bacteria that we couldn't get completely cleaned off, and we're not getting an accurate urinary tract infection. We don't know what that bacteria is there. So we do a urine with a urinary culture sensitivity, mostly by cath. Older children can do a midstream and do it quite effectively, but the young ones, we do cath. We can do even the tinier infants, the premature, we do a suprapubic aspiration. And it's literally cleaning off the lower belly above the symphysis pubis. And we go directly in and we take a syringe and we get half a cc of urine out. Yes, it's uncomfortable, but we don't have a catheter small enough to get the urine out of the itsy bitsies, and many times they are urinary tract infections, which is causing them their problems. So it's important that we get a good specimen. We do, as we go on and the severity of urinary tracts, continue to do different exams. We could do the kidney tap. We can go in, put a catheter in and wash in whatever, sediments in there, ultrasounds. If it continues on, avoiding cystourethropy, is there some sort of obstruction in there? What's going on? And then the IVP, intravenous pylorography, that's usually used for kidney stones. And then, of course, we can go to kidney scans and all sorts of things to evaluate them. Now, sometimes we have to do a renal biopsy, and renal biopsies goes directly through the back, and it's usually a child who is going to get some sort of sedation. They're not going to be completely knocked out, okay? They could get a little bit of midazolam to help them relax. Nothing to eat or drink, and they're going to have to be placed either sitting up or on their side, depending on the age, depending on the physician. We want a baseline vital signs before we start. Make sure that there is a consent sign of always. And then after it is done, it's very important for a child that has the ability to have pressure and a pressure dressing on that area. Very, very similar to post-op cardiac cath, but it's nothing to do with moving legs, okay? So we're going to keep pressure on there, pressure on the dressing. We're going to look for leaking urine, even leaking blood out of that area. Bed rest, 24 hours. And because we've gone into the kidney and could be leaking urine inside the abdomen, we're going to be checking the abdomen, making sure that it's not tender, swollen. And of course, urinary output's going to really tell us, is the kidney shutting down or is that urine going inside? So kidney biopsy, NPO before, pre-medicate, make sure they got good vital signs, make sure that dressing is a good pressure dressing or a sandbag if you possibly can, and cannot get out of bed for 24 hours. And as a nurse, monitor that belly intake output. Now, I said with the cystourethropy, sometimes they're looking for some obstruction, and obstruction could be anywhere. If it's going up above the bladder, up the ureters, we think of hydronephrosis. It means the kidneys are just getting full of water and they're obstructed. Sometimes we have the ureters that are going to be obstructed, and it could be anywhere in there. So if it's, vesicle ureteral, it could be the vesicle, the bladder, and the ureters. Is it one side, both sides? These things can occur. And when we look at urinary tract infections, and we're getting a lot of them, we're going to think obstruction somewhere, something's going on. Now, nephrotic syndrome has a lot of the properties of what you say a kidney problem, but it is not kidney failure. Let me say that again. It has nothing to do with kidney failure. It has to do with the body's inability to keep proteins in the body. And the urine just pours out protein. And where does protein normally live? Well, it lives in the albumin, the protein in the blood. So blood protein, proteins leaving. So you are going to see all of those fluids coming out. And you might see that the urine looks like a foaming glass of beer, but it's that foaming, it's that protein that you do see in there. So massive loss of protein. Well, if intracellular doesn't have protein, what's going to happen? It's going to start spewing fluids into the interstitial spaces. This child's going to blow up and be swollen because protein, isotonic, hypotonic solutions of the intravascular and the extravascular space, these really make a big difference. So proteins are huge. So what happens in it? Well, we're going to lose proteins. You're going to see that we're going to be hypovolemic because we're getting rid of fluids. Has to do with hyperlipidemia also. But again, it's all down to big swollen eyes, swollen everywhere. And it is a lifelong condition. This isn't something that we can cure. It's not like a glomerular nephritis, which we can cure. This is something that they have to live with. It's the body's inability to store protein. These children need, because of the swelling, edema, need to be on salt restriction, fluid restriction, low salt diets for sure. Now, they even swell in their mouth sometimes, and it causes sores in the mouth. So loss of appetite is a big thing for them. These children, because of not having a lot of extra fluid, they really need their activity not to be as vigorous as going and running track for, a 3-mile run. It wouldn't be a good thing for these children. And this family needs support, especially the child's going to need support from his brothers and sisters about the salt and not having salt and decreasing fluids, because, children can tease their brothers and sisters. I had 6 brothers. They teased me every day of my life. But if it was something to do with medical like this, I would hope to say that they wouldn't tease me that I couldn't have an extra drink of whatever, or I couldn't use a salt shaker. So what is the management? As I said, we are going to try to somehow reduce that urinary protein from occurring, okay? A lot of times we put these children on steroids. It's the way that we calm down the inflammation of the protein being lost, okay? We're going to decrease the amount of fluids that can go into the tissues, and infection. We're going to be monitoring them for infection. And we are the biggest nursing priority in nephrotic syndrome is strict INO and daily weights. We can see if their fluid is increasing or decreasing. So very important for us, intake output daily weights. Now, I just sort of mentioned arbitrarily glomerular nephritis. Well, glomerular nephritis is another one of the diseases like rheumatic fever, right? It's caused by strep infection. This is the second one. Remember I told you there was 2? This is the second one. And this literally will go to the kidneys and it will attack it. Usually 2 to 3 weeks after the infection, we will start to see these things. So what happens? Well, child stops urinating or minimally, starts to swell up, and with that comes that elevated blood pressure. You might see blood in the urine, and you might see it dark from the protein that is in there. So if it's due to an acute glomerular nephritis due to a strep, we just put them on the antibiotics. And the antibiotics will recover from it most of the time. Again, this could be something that also turns into a chronic disease if we don't get it quick enough. So managing edema, daily weights, I and O, and we're going to be measuring abdominal girth because it has to do with the kidneys. Nutrition, as I said, low sodium, fluid restrictions, and we have to be careful of infections with these children. Now, I mentioned hemolytic uremic syndrome. It is an infection that literally has anemia with thrombocytopenia, and this child is going into renal failure. Usually it's due to an infection, E. coli, which is in the GI tract, and it literally goes into the urinary tract infection. And these children will start to see bleeding in their urine and maybe other bleeding things. Remember, thrombocytopenia, platelets, always put them on a bleeding precaution. We've mentioned Wilms tumor many times. Remember, it's off the adrenal gland or it's off the kidneys, a nephroblastoma. Boys, ages 3 to 5, and African American. We know it's a swelling. We take care of it by chemoradiation, surgical removal. And again, do not touch that abdomen. It's very fragile and it will break pieces off into the belly. Kidney failure happens in children. We have acute kidney failure. Could be due to a couple different things. Could be kidney disease or a urinary tract obstruction. That kidney can't drain, and there's an obstruction, you get the hydronephrosis and you could kill the kidney. Maybe we could turn it around by relieving that obstruction if it was caught early enough. And then we have the congenital or the chronic type renal failure, and it's usually a congenital anomaly. So acute renal failure, what is it? It's the kidneys can't do what they're supposed to do. They can't filter the blood. We mostly see children who just stop urinating or very minimally. And what we see in adults, we see in children. There's no difference. We're going to see the potassium elevated. We're going to see BUN creatinine elevated, metabolic acidosis. All of these things we're going to see. And we're going to literally do the same thing as we do in adults. But the one thing that can cause this renal failure in children is as simple as dehydration. Children who are vomiting and diarrhea, and they get to the point where they're 2 years old coming into the ER with a heart rate of 180 at rest. I'm scared because now this is a setup for renal failure. And I always ask, so when's the last time did they urinate? Because when we talk dehydration in children, it can affect the kidneys. Chronic renal failure, again, it could be born with the kidneys not working that well, and then we start to see in them deteriorating over time to the point, where they're barely working at all, and these children are on dialysis. So what happens? Why are kids with renal failure? As I said, sometimes it's that urinary tract malformation, or it could be reflux. There are little valves coming off the bladder, the vesicle, going into the ureters, and those little valves are open, and we see reflux going up, and it can go into the kidneys because the bladder literally is not as sterile as the kidneys because it's close to the opening to the outside. So when this has a little infection goes up into the kidneys, it can cause infections and can cause the kidneys to go into failure. Sometimes it's hereditary. I was very surprised at the hospital where I worked. I did nursing clinicals for an area hospital, and I was on a floor that I didn't work on, and it was the GU floor. It did have a dialysis unit up there. And I was like, why are kids with renal failure? I was, like, what? Why are kids like that? And what I was told, what they had seen, many children had, the parents had married interfamiliar, marrying first cousins. And this caused these defects from going on. And it was like, okay, I just never thought of it that way. So it could be hereditary. It could be that chronic pyelonephritis, chronic glomerular nephritis. Lupus can kill any organ, so it could be lupus. And then anaphylaxis, and anaphylactoid purpura goes in and it will destroy organs too. So how do we manage chronic renal failure? Well, we want to have the kidney work as well as it can for as long as it possibly can, right? For sure. Electrolyte imbalances are huge. So we want to keep that potassium under control and the other electrolytes there. One of the things that is so common, adults or children, is their hemoglobin hematocrits are chronically low. It's not uncommon to see children with 7 and 21s, 6 and 18 hemoglobin hematocrits. You can give erythropoietin, and that stimulates the own body to make their own red blood cells. So that is a great thing instead of chronically doing blood transfusions. And again, any kid with any diagnosis at all, we want to try to keep them as normal as possible. I mean, it's hard when you're tied down to a dialysis machine 3, 4, or 5 times a week. Now, types of dialysis. This tube in this child's abdomen is a peritoneal dialysis catheter. This is the dialysis of choice in your small children. You cannot put a small child on hemodialysis. The flow of blood is too strong, and because their veins are so fragile for the first, bit of life, that it could actually go up and blow the veins and causes intraventricular hemorrhages. So the only way to give a child the function of a kidney is through peritoneal dialysis. Peritoneal dialysis is done by parents, done at home. It keeps them home. So what do we do? Here's another look at the dialysis catheter here. What we do is we take a machine that has a warming bin and we put fluid, whatever the nephrologist has ordered, whatever the fluid is, put it on, and then under sterile technique, we gown, put a cap on, mask on, gloves, and we go through a process to hook up that catheter to this machine. And what it does is literally puts in this fluid, this what we call diastolate, into the abdomen, and it sits there for a certain amount of time. So we have a still. So we insert fluid, then it's a still. It sits there maybe 20 minutes, half hour. Then there's a drain, and then we drain it for a certain amount of time, and it goes into a Foley catheter because we'll be measuring the fluid coming out. Now, we might do 8 or 10 cycles a night, which means we put in fluid, it sits there, and then draining. This is 8 or 10 times at night. What is our responsibility as a nurse besides knowing how to hook these up? Now, I first went to work for this hospital, and within 2 or 3 weeks there, I had a child with peritoneal dialysis. So I went to the course. They were holding it right away. So I learned how to do it, and I'm glad I did for the parents, and made me understand the concepts of it more. So if we are looking at nursing care after it's hooked up, we will be making sure that the belly is soft. We will be making sure that the liquid that comes out of this child is the same. If it turns colors, you see sediment, there's something wrong, or you see some tenderness in the abdomen that wasn't there. This is peritonitis. This is their only filtering device for their kidneys. So as quick as we can get it, start antibiotics, the better the outcome for the child, because without dialysis, they're not going to live. And the only dialysis they have is a peritoneal dialysis. So make sure that we do monitor that drainage fluid color. And if we see anything we suspect, call the doctor, get the antibiotics. I had a girlfriend who at age 64 put herself on peritoneal dialysis, she was in a renal failure, and she did it for several years. She really, every night would hook herself up and it let her be herself during the day. So what best describes acute glomerular nephritis?
to be B.
B.
Again, it occurs after a streptococcal infection. Yes, very good. So GI, now there's a lot of GI stuff, more than you can imagine. Well, first thing, let's talk about absorption. We know that there are diseases that we can have that don't let you absorb certain sort of vitamins and minerals. You think cystic fibrosis, you think of your fatty vitamins, right? So all of these things can cause problems, and you're not getting proper nutrition to grow as well as they should. Then we have food allergies, and food allergies could be as simple as maybe a little bit of rash at the bendy of the arms or knees, or it could be all over the body. Or it could go up to the point of anaphylaxis, but usually in infants, we're just going to see little sort of rash somewhere. Sometimes under the neck, we're going to see something, or we're going to see the kid a little crankier. Or we introduce food at 6 months old. And this is usually when we're going to start to see these allergies. That's why we wait, 3 to 5 days in between the introduction of every food. Lactose intolerance, we'll see in vomiting, we'll see in diarrhea, we'll see constipation. All of these things are clues something's wrong. This child's having an allergy. So in GI, there's some things that can occur. Again, we're spitting up, we're not getting all of our nutrition, so growth failure. No nutrition, cognition, and growth are going to be delayed. You'll see that with spitting up, nausea, vomiting, diarrhea, constipation. These are all key things, and physicians will ask, so when was the last stool? What did it look like? How many times a day is normal? Any child that's going through any GI workup, I will always tell them, write everything down. You're not going to remember. Anybody who changes a diaper with a stool, have them write it down. Grandma's in the house, your best friend, write it down so that they can follow up and give it to the physician, because it gives better signs of what's happening. We can tell if a kid's in abdominal pain, their legs are going to be kicking, and you will know, and they'll be crying. Bellies will be big. If you see bleeding, that's an easy thing. Discoloration and jaundice, we know biliary atresias. This is GI problem. Anything with a small bowel and the common duct, in the liver can cause it. There are children who have problem with swallowing. Pierre-Robin syndrome is one of those syndromes where there's problems, a little tiny little jaw, and they have a hard time swallowing and chewing. Some of those children need G-tubes for the first couple of years of life until they literally grow out of it, and then we start feeding them by mouth. And we know if a child has a fever, they're burning fluids in the body, and these children can get dehydrated, which I think you've already heard from me is extremely dangerous in children. So a child with a fever, I don't care if they eat, but I want you to drink as much as you can. I want to prevent that dehydration. So here we go. Dehydration. What is it? Well, it's when you don't get enough or you're losing it through some other way. Insensible fevers. All of a sudden you're urinating a lot. That could cause it. Or vomiting diarrhea. If you look at this little baby here, I can tell you this child, just by looking at it, is severely dehydrated. Looks like they're sort of sitting up and they're quiet. That fontanelle is sunken and they're just sitting there. But look at the color of this child. It's pale. Even the ears are pale. That is such a telltale sign of dehydration. If we could see the eyes, they could be sunken back in the head, and we would see those dry lips also. And then, of course, there are other things that can cause dehydration too. So how do we measure accurately intake and output? That's always a question. So what do we measure? Well, urines and stools. If we can measure the vomit, if this child is under severe intake and output, it's very important. We can put a pad underneath the child, weigh it before we put it under them, And if they're sweating, we can get what came off of them, and we could get an telltale close to what they're sweating out. Their vital signs are a big thing. In dehydration, high heart rate, the heart's trying really hard to beat the little bit that's there. And of course, the blood pressures are low. Skin turgor is going to be horrible. Mucous membranes are dry. Capillary refill prolonged. And we're going to see it in their weights. That's why every single infant's weighed every single day in the hospital, whether they're in an ICU or on a floor. It's just something that we do. And of course, I love fontanelles. I love it when infants have it because it tells me everything. And then children, as they get older, when they're really dehydrated, they're not going to be responding quickly. We know children who don't feel well, you're going to not really be able to wake them up as easily, or they're going to be just sitting there and not playing. Well, this is telling me a lot. So there's all different sorts of types of diarrhea. It could be just they're having it due to infections. It could be something to do with infancy, and it has something to do, some children just get it more than others, and some of the reasons we don't even really know why. Now, how do we treat diarrhea? Well, we don't stop feeding a diarrhea. We do not stop feeding. We might change the diet to less fat and maybe put them on crackers and food. But in diarrhea, you keep orally feeding them unless they are severely, not alert and they're extremely sleepy, then you'd give an IV. But most of the time, diarrhea, give them something by mouth. Oral electrolyte therapy, Gatorade, Powerade, Pedialyte, one of those things. And again, if they're really, really lethargic, IV, but most of the time we'll feed them. And a lot of times we'll just give a lactobacillus to these children. And again, starting them back with their diet. Years ago, they put you on a brat diet. Have you ever heard of a brat diet before? That's what they used to. Now they're saying just feed them. Bananas, rice, applesauce, toast. That was the brat diet. I mean, it's still not a bad start in any sort of diet, but feed a kid what they want. Just keep feeding them, because if you have diarrhea and you don't give food, what's going to happen? It's just going to be liquid, and that's what you don't want. Now, constipation and children. Many children get constipated. It could be due to their diet or something in their intestinal tract. But many times, constipation in children is because their bowels is the only thing a child can control. Sometimes when they're going through stressful periods, they can hold their bowels for 7-10 days and not move their bowels at all. And they do that, they just don't bear down, they just leave it in there. And sometimes if we are in chronic constipation, it needs to be something they looked at. And when we're looking at constipation, we know that constipation causes urinary tract infections. So if we're in chronic urinary tract infections, we must make sure the stool is moving well enough. So many times when you have a problem with your urinary tract, they'll send you to a gastroenterologist, a GI doctor, because they want to make sure that your stools are moving adequately. So we've been talking about being constipated for the first day and a half after birth, and we've mentioned these things, and we know cystic fibrosis, hypothyroidism, two things we really look for. Well, now we're going to look at intestinal atresia, stenosis, and Hirschsprung's disease, and we're going to show you why those things can cause constipation also. Now, usually constipation is due to diet. Usually your breastfed infant has looser stools. They just tend to go every diaper. Formula-fed infants tend to have more chance of having constipation. It's just what it is. I don't know the reason, but it is what it is. So Hirschsprungs. Hirschsprungs can cause constipation at birth. And what is Hirschsprungs? Hirschsprung's disease is there's this area in the descending colon that has no nerves in it. There's no nerves. So that means it can't squeeze down, okay? And it stretches and it collects stool, and you could have a big pouching going on in your colon, but it's not coming out. Now, if you look at the bottom of that picture where it says rectum, sometimes it's little bit will squirt out there. That's why there's ribbon-like stools. It's like putting it in one of those pastry icing things, right? You only can do a little bit coming out. So Hirschsprungs, aganglionic, no nerves. Sometimes there's so much pressure, you can get a little bit coming out that little tiny little hole there. So you see ribbons, okay? What do we do for Hirschsprung's disease? Well, when we're seeing there's no stools, we are going to do an x-ray of the abdomen, and just a simple x-ray is going to show this outpatching going on in the intestines. I mean, this is how we're waiting for the CF study and the thyroid studies, right? So we'll be checking this. If we see that it's a possibility, this is a piece of bowel that doesn't work. It is literally causing problems. It needs to be removed. So they go in, do a biopsy, just a simple sigmoid, little biopsy, and they're going to find under a microscope, there's no nerves in that area of that bowel. So they'll go and they'll take that piece out. Many times, these children will end up with a colostomy for a couple months, but it is most of the time reversible. So Hirschsprung's, no nerves, no peristalsis, out patches, little squirts through, little ribbon stools, and we say, okay, get it out. We take it out and put a colostomy in, and then these children actually do really well.
My son has that, Professor Boger.
Really? Really?
Yep, it's hereditary. He has it, my husband had it, and his mom had it.
Wow. Did you see the ribbon stools?
No, he actually had no stool.
No stools. So he had really narrow. Were they able to reverse the colostomy?
Yeah, he had it for about a year.
That's awesome. Wow. Wow. I've never heard a student tell me that before. Thank you for sharing. It's interesting to me. Okay, and now we have vomiting. So we talked about diarrhea. Now we're talking about vomiting. Well, if you're vomiting, do you want to give something orally? If you're vomiting, really vomiting? No, because if you constantly give fluid in, they're just getting rid of it. And now you have a chance for aspiration, and we don't want that. So if we are just vomiting, we need to, number one, to determine really how bad are we? Well, the first thing I'm going to do is put my stethoscope to their chest and listen to a heart rate. Is it normal or is it a high number? And then take a blood pressure. And if it's low, skin turgor, how dry, dry diapers. And I'm going to know this child's dehydrated. So we'll start an IV most of the time on children vomiting. We'll start an IV. And of course, if we're already putting a needle in the vein, we're going to draw some blood too. And we're going to be looking for really the potassium. If you vomit a lot, you're going to see a low potassium. And that makes you feel horrible and crampy too. So let's go ahead. Let's start an IV. Let's, give them something for their vomiting, that aldosterone, the Zofran medicine, and then slowly, a little bit later, start with little sips of fluid. Sip, 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 sips. This is where we hold the food. This is where they get sips of fluid for the first hour or so, and then slowly add in a cracker, etc. Now, sometimes in children, they have reflux, just like us old people do, right? Where it's just reflux, and children show us things differently. Now, an infant can have reflux, and many times you see it. Sometimes it's because the child's not burped properly, or not positioned well after, or overfed. These children will literally arch. You will see their heads go back, their backs arch, and their legs will spew, and they will cry. And you know that they're refluxing. You can almost feel it the way that they push their abdomens. Now, sometimes we can treat reflux. Most of the time, we can treat this with just medicines. We can put them on the ranitidine, the Pepcid, and sometimes you'll put them on, Propulsid, bigger Prevacid, other different drugs, and we can get them okay. And we do use adult medicines, but again, in pediatric doses. But sometimes it's so bad that they keep aspirating pneumonias because of it. We might decide to do something called a Nissen fundal plication. And what that does, it takes the flip of the stomach and pull it up to the esophagus so it can't go up. So you're preventing reflux. Most of the time you hear about a Nissen fundal plication when you put in a gastrostomy tube. Most of the time they go hand in hand because you don't want to put in a big amount of liquid feeding and then it goes reflux. So many of these surgeons do both at the same time. It's the prevention of reflux. Now, there are children who are older who end up with reflux. And the way that we figure those out is this kid has this cough, this like something in the throat, coughing, and then that heartburn that goes along with reflux, just like grandpa did, right? And of course, maybe some abdominal pain. Acute appendicitis. Now, appendix is that place between the small and the large intestines. There's a little thing called appendix there. And sometimes in children, it says, I don't like it in here. Let me get inflamed so you come take me out. What do you see? Same thing as adults, that right lower quadrant, rebound tenderness, McBurney point, all of that. The one thing about appendix is when they stop hurting, we know that appendix has ruptured. And the biggest concern and what we're rushing against the clock for is to prevent it from rupturing because it causes really bad peritonitis. Now, if your child had appendix and it ruptured before they could get there and get it out, certain things are going to happen. Well, our whole intestines has been inflamed. It's had, all of the insides have gone over the intestines and they're just red and they're angry. So we need to rest the intestinal, everything in that belly. So NPO. Also, because of fluids, we normally secrete normal stuff and we don't want that to happen. We're going to have an NG tube down to keep that area decompressed, to keep the gastric juices and other juices from going down and irritating that belly. These children need to be up, out of bed, all of the things for post-op care, coughing, deep breathing, pain management, IVs, and then, of course, IV antibiotics. And that would be the treatment for appendix, especially when the ones that have ruptured. If it's not ruptured, these children are home the next day. It's pretty quick. They'll take and put them on some oral hydration, usually electrolyte fluids, and then they'll get them up, moving them, giving them something for pain as needed, and usually they go home. Now, Meccal Diverticulum is literally this little piece of skin that outpatches inside the intestines, and inside there is a blood vessel, and it rips. So it just causes bleeding to go on inside the intestines. But that little thing didn't have a nerve, so it doesn't hurt. So we call it painless rectal bleeding. This sometimes happens. It's not a big thing, the amount of children, but it can happen. And you need to go in there and take that little piece of tissue that's bleeding and it needs to be removed, basically. It's a surgical procedure. IBS, we have ulcerative colitis and we have Crohn's. You know, IBS is anything mouth to anus. That's what I call it. We have ulcerative colitis, which is segments of tissue that can cause inflammation, pain, diarrhea, bleeding. And the big thing with these is, you know, finding out what causes it. What is it? So what do you need to treat it with? You know, steroids are a good treatment when you're in that flaring moment, but diet is huge in these children, not to eat things that do upset the abdomen and the belly. And sometimes they've got to go in and remove pieces. So if we can keep this child stressed down, we can get them on a proper diet, following the proper medical regime, they can do very well. But if they're not going to follow what they're supposed to be doing, eat wrong things, they will suffer for it. Children do get ulcers. You know, children are little worriers. You know, they tend to worry more than we really realize. How do we treat them? Just like adults. We're going to give them the same medicines. And if they have a perforated ulcer, which can happen in a child, we'll do that, you know, gastrectomy and that removal. So again, we're going to give them good diet, place them on the medicines that are adult medicines, but milligrams per kilogram. Liver diseases, we know children are going to get liver diseases too. It could be an acute or chronic. It could be from a virus or not. It could be autoimmune, could be, you know, the cystic fibrosis is in there creating problems with the common bile duct. It could be lupus attacking the liver, anything. Now, the thing with inflammation of the liver, number one, make sure that it's patent, it's open, that all the ducts are open. That'd be number one, because you don't want a biliary tract atresia at all, because then nothing's flowing. But how are we going to tell a child or even an adolescent, how are we going to take the best care of them? And with hepatitis, they should be on a high protein and carbohydrate diet. They need to keep up the calories to prevent muscle wasting, and they should be on a low fat diet. Remember, liver, fat digestion. If we don't have a good liver, we're going to have a lot of gas and discomfort. So high protein, carbohydrates, low fat. And remember, with hepatitis, with adults, again, with adolescents, to make sure always safe sex is a big deal with that. Cleft lip, cleft palate, they're born with the closure not completely done. It's hard when you have a parent looking at their child with this opening, and you wonder, what are they thinking inside? You know, I think it's the support of a nurse teaching them that we will fix this, we will make it look better. It's going to take some time, but you know, we will fix it. But your child's got, look at those beautiful eyes, or look at all of that hair. So you try to, you know, take them away from just the general appearance. It could be one side, both sides, and it could be palate or no palate. So the cleft lip, they close first, because think about feeding. These children need to put their mouth around a bottle or a breast to eat. So we try to get it done fairly quick. So about 2 to 3 months. And that little Logan bar there, that little thing that's there, is to prevent them from getting to their lip and picking at it, because that's what kids do. And if you notice, they have elbow restraints on the kids, so they can't bend and grab it, so that we keep the scar down. Because if you think there's like the darkened area of the lip, they've got to make sure that's approximated really good so that they don't have a crooked lip when they're all done here. And then we have the palate, somewhere between 6 to 12 months, 8 to 12 months, is they will fix the palate. The problem of not fixing it, you know, fixing it too late, again, is speech development. They will talk like that because they can't make a form sound. So fixing it can really help them with their speech. That's the big thing. And again, the palate open, there's all sorts of things with aspiration. So as I said, big thing with cleft lip, cleft palate is feeding them. If you look at this bottle, that top area is very soft. And you turn the bottle open and you put it in the child's mouth and very slowly you squeeze it. So you're getting, they think they're sucking and they're swallowing. So it gives them that comfort, because how do infants comfort themselves? Everything oral, right? So if they can't suck on a pacifier, or at least we're giving them a bottle, they feel like they're getting there. Because if they're not eating well, what's happening? Nutrition, growth failure, and cognition delays. Another thing that can happen is the failure of the esophagus to go and be connected to the stomach. It's called esophageal atresia. Another thing is a connection that can happen with a fistula between the esophagus and the trachea. And that means if you swallow, food goes directly into the lungs. So if you have no connection between the mouth and the stomach, where is it going to go? Into the lungs. And then because some of these children have a connection between the trach and the esophagus, down the esophagus into the lungs. So these things, both children with this condition will be made NPO. Usually what you're going to see, this kid's going to have foaming and gurgling at the mouth, and they're going to be choking and gagging, because when they're swallowing, it's going into their lungs. And that's usually what you'll see with an infant if you do not suspect it at birth. So what is our big goal? Well, as I said, everything's open and it's going to the lungs. We need to protect those lungs, prevent that pneumonia. So what we do is we will place this child NPO, nothing by mouth. An NG tube, it's not going to go down anywhere because there's no connection to the stomach anyway. So IV and then IV antibiotics. And why antibiotics? They're constantly aspirating food into their lungs. They need to prevent pneumonias. So we give antibiotics for that. These children do well. Just because they're missing this connection, there's no cognitive delays or anything. They will be otherwise normal, healthy children. Hernias are a protrusion through the abdominal opening. I think the biggest one is that umbilical hernia that you see on that picture, the belly button with a little baby's hands. And you push it in and out and it's soft and we know it's fine. The most horrible of all of them is a diaphragmatic hernia. This is the diaphragm didn't form, and the intestines are up in the chest and they're pushing against the lungs, and this child cannot breathe. His lungs are being squashed, and this child will be an extremely ill child. The diaphragmatic hernias usually end up on ECMO, then have to have surgery to get those intestines back down, make a mesh for the diaphragm, and they will only have one lung, because that left lung has been squished intrautero and never had a chance to form. And a hypertrophic pyloric stenosis. Now, we talked about reflux and just spitting up a little bit that some children do. And if it's too much, they're losing, nutrition. Thing called this pyloric stenosis. And this is vomiting, but think of The Exorcist. Out of the mouth, across the room, like I didn't know that baby had that much food in its stomach. And it will hit 10 feet across the room and splat on your feet. That's how forceful a pyloric stenosis is. Now, what happens is that valve that connects the lower stomach to the duodenum, the intestines, is hypertrophic, or it gets very thick. There's a thick muscular ring and it holds it shut, and there's no hole to go down, barely a hole. You can actually feel that little hypertrophic area. It feels like a little olive. It's the size of a little olive in there. You feel that. So what do we do? So these children are usually 3 weeks to 2 months. These are young infants. So parents are having a moment. I mean, you have a newborn baby and they're vomiting like the exorcist and what's going on. And they're afraid because now you said, oh, now your baby's going to surgery. So these poor parents, this poor hormonal mother with their infant takes a little bit of time from the nurse to really help them through this. Now, as soon as we get an infant in with vomiting, first question, so what does it look like when they vomit? Does it dribble down or does it get forced out? And if they say it's forced out like a lot, I would ask them, would you please not feed your infant anymore? Because this child's going to surgery as soon as we can get them upstairs, because we don't want them vomiting and aspirating, because that's our concern. So we make this child NPO. We don't want anything in that stomach, okay? We're going to start IV fluids for when they go upstairs. And we might even start an antibiotic on them, you know, for any prophylactic. That little valve, when they come back to the floor, once they're woken up, they will start on clear liquids. And usually within a day or two, they're back home. And very minimal scars left on this child. It's just a pyloromyotomy, it's called. The myo, the muscle is opened to allow the fluids to go down. And these kids don't have any problems later on in life. It's just something that happens once. Intussusception is usually, I see it in kids ages 3 years to 3 months. I've seen one kid at 5 months. It's very rare, very young. Usually is that 1 to 3 years old. These kids come in screaming. Their legs are just flailing. They're in so much pain. I'll come up behind them and try to touch their belly and it will be tense. And what it is remember your intestines are full of nerves and it sucks up into each other like a telescope. That's intussusception. And usually these children, they'll take them, and if they are still in pain, we do an ultrasound, we'll see it. Many times they'll stop having pain and they're running around the room like nothing's happening. You know that it's popped out by itself without any intervention. So to do an ultrasound wouldn't give us a picture. Many of these children, we end up just, they, you know, resolve by themselves. We put them on a high fiber diet to keep that intestines open and tell them come back in if you need it. Now, there are times where they waited so long and it swelled so much that it's not popping back out. They literally do an air enema on these children, and it's done by the radiologist under fluoroscopy, and they pump air into the rectum and they pump it up and they watch it pop out, and hopefully that's the outcome. Once it's out, these kids feel better and they pass a lot of wind and they're just happier. Sometimes though it doesn't work, and that's maybe 10% will need surgery, and some of them need a piece of their intestines taken out at that point. Malrotation in volvus is something to do with the embryonic stage where it's twisted around an artery or ties up against itself, and these children come in sort of looking like an appendix but in the wrong place. It's more diffuse over the abdomen. Again, these things, the peritonitis is what we're fearing the most. So if we are seeing pain in the abdomen, we don't know quite where, you know, we'll probably do a CAT scan on this child to try to find it. I've seen both of these things and they both look like an appendix, but in the wrong place. An imperforate anus. Look at that little baby. He doesn't have an anus at all. Some infants are born that way. So that child needs a colostomy right away because there is nowhere for stool to come. There's no place for, it to go. So this child will have a colostomy. There's all sorts of fistulas that can occur. They can go in between bladders and intestines, between a bladder, genitalia. Sometimes you'll see stool coming out of the vagina. These are telltale hints that there's something going on, and let the physicians know. Celiac disease. This has to do with your small intestines.
Ms. Bogart.
Yes.
So the one that born without anus, so they're gonna have that forever?
You don't have a sphincter. You have
Okay.
no anal sphincter. So yeah.
Okay.
I know. I think the same thing. Poor little baby.
Yeah. Thank you.
No, you're welcome. So celiac is small intestines. It causes steatorrhea because it doesn't absorb fat, and it stinks. There's stools. It's really what's called malodorous, or it stinks rightfully bad. Because you're not absorbing all of the vitamins that they need, that they are going to look malnourished. And these children need vitamin supplementations, and they need to be on a low gluten diet. You can have fruits, vegetables, chicken, salmon, tuna, beef, eggs, cheese. I mean, you can have an omelet, you can have a glass of milk, you can have a banana. I mean, it's just get away from all of the bread type things. That is what you do avoid, but their diet still can be good. And today they're getting so good, even at Publix you can get gluten-free breads for these children. Years ago they didn't have it, so it's a good thing. Short bowel syndrome is, for some reason, the bowel is too short. Now, one of the things that can happen, and we see it a lot, especially in your high-risk newborn infants, whereas they've had an hypoxic episode, and this has caused some hypoxia to the intestines. So when they're fed, the food goes in and it irritates it and causes something called necrotizing enterocolitis. The initials are NEC. Literally, the bowel dies. This is why we do abdominal GERS and look for aspirates in the feedings to make sure the food is going down the way it should. Because if it's not, this child could have a piece of bowel that's dead. Now, depending on how big the portion of bowel is, I've seen 58 centimeters of the small intestines removed on my little girl called Jessica. And she forever and ever has short bowel syndrome. So she had a G-tube when she went home for nutrition, high caloric nutrition during the day. And she had in, a Broviac, like this little boy here, so they could get hyperalk and lipids at nighttime for nutrition. So short bowel syndrome, you just don't have an intestines. There's no place to absorb what you need from it. So you've got to give them the best nutrition you can, and this is the way that you could see it. They're talking about gastroschisis here. It could be the intestines born on the outside. It could be the bladder born on the outside. It's called a midline defect in the child. And literally, they'll hold this stomach, put it up like in it, they call a teepee, and slowly the surgeon will push it back into the finally where they have enough room, and then they will close it. And the kid does very well with it. It's just not a good look when a baby's born to have his intestines on the outside. And we know children love to eat many different things. I think the most common they like is Tylenol, ibuprofen, and Flintstone vitamins. They just think they're good, they're candy, and they just start eating them. Now, Tylenol, of course, acetaminophen and ibuprofen can be very dangerous. Usually vitamins without iron, they just have you watch them, but you'll get rid of those vitamins. You'll just, urinate them out. But if it has iron in them, now we've got a problem with iron problems. Other things they like to eat is things like rat poisoning. They'll see it on the floor and they'll stick it in their mouth. That also is very dangerous and causes bleeding coagulopathy. So again, bottom line to the story is make sure that we have all this stuff put away and safe from these children. Any questions? A lot of stuff, huh? What I'm going to do is put up the Kahoots. Who wants to win a Kahoot today? Leshin wants to, okay. Kristen, you're always there. Carly, okay. Dina? Tiffany, you maybe? Where did you go? Hold on. All right, let's just get going. I believe there's 50 questions today. All of the following are symptoms of dehydration in an infant. Remember, when you're talking about dehydration in children, it's a very scary thing, and we need to correct it as soon as we possibly can. So what do we need to know? Well, you're going to see that dry, pale skin. You're going to see that, capillary refills way down. The elasticity is down. And of course, you're getting weak and lethargic. You would see a decrease in urinary output, not an increase. What is priority treatment for a child with dehydration due to profuse vomiting? How do you take care of that? So if you're vomiting, you're not going to give them something by mouth. Profuse vomiting, that means a lot. Don't put anything more in their mouth. What you're going to do is give them IV fluids, give them an antiemetic, and then after a while reintroduce something orally, but you don't want to continue the vomiting cycle. What is a treatment for an infant with diarrhea lasting for 4 days? What's the treatment for diarrhea? So diarrhea, you're going to feed them. Vomiting, no. Diarrhea, feed them. Okay, so diarrhea, we're going to feed them the oral electrolyte and start to introduce foods, low fat, maybe some breads and crackers, whatever, cereals, but IV fluids, not unless they are completely, lethargic. What acid-base imbalance might you see with a child who's having profuse diarrhea? So we are in a metabolic acidosis when you are having profuse diarrhea. The GI tract has a lot of alkalotic things, especially those things secreted by, the organs in the small intestine. So you will have metabolic acidosis. Now, I'm including, you'll see acid-base imbalances on many of these cahoots. I saw 4 different questions on the HESI regarding acid base. Also, I know it's on your NCLEX, so that's why I've tried to incorporate that in here for y'all. A multi-select. If an infant has not passed the meconium stool within the first 24 to 36 hours, what would you assess for? So hypothyroidism, Hirschsprung's, yes. Cystic fibrosis, yes. What does stool have to do with an electrolyte imbalance? Has nothing to do with it. Deficiency of vitamin D causes what? As I said, with the GI system, especially the small bowel, there's a lot of problems with the absorption of vitamins. So if I didn't have enough vitamin D, it would cause rickets, because vitamin D has to do with joint and bone growth, okay? Scurvy is vitamin C. Remember the fishermen on the fish years ago, the 1800s, had to carry oranges with them, they realized. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So we know this one is IV fluids. Unable to drink or eat anything with profuse vomiting. That's your answer. We're going to give IV fluids. Give a bolus, 10 to 20 per kilo, and go from there. A multi-select. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? So remember, ruptured appendix has spewed the stuff from the intestines inside the belly. You're in acute peritonitis. How are we going to treat that? IV antibiotics, IV fluids, NG tube suction. We want to keep that bowel decompressed. That bowel is angry from all of those secretions that leaked out into that abdomen. And then because it's leaked out, your tissue is not going to be as healthy. Always assess that surgical site. Complete bed rest. Any child who's had surgery, any adult who's had surgery, especially with this, needs to get up, needs to get out of bed, need to walk. We want to get those bowels and the gas moving again. So we're going to be moving around. No complete bed rest. Passage of urine, usually at night in children who should have voluntary bladder control, is called what? So in this question, we see 2 things that we haven't seen. Epispadias is when you have a male, instead of the urethra coming out at the tip, the hole comes out on top. And if it's hypospadias, it comes out in the bottom. The holes there, it's not on the end. And the treatment is to take the skin from the foreskin, and we're going to do plastic closure so we can't circumcise this child. We're going to have to put it either top or bottom. Usually 6 to 8 months we do it. And then what they do is to make sure they keep that round and that hole open, they'll put a stent in to go home with. It sort of looks like a straight calf that you would use on even an adult female, that little 8 French, a more rigid tube, they put it in there. What is Hirschsprung's disease? So Hirschsprung's is the absence of parasympathetic ganglion cells, which basically means there's no nerve cells. The bowel doesn't move, doesn't go through peristalsis, it's no nerves, it doesn't feel, it needs to be removed. Remember, this is where you have that little tiny opening on the bottom, and you might see a little bit of a ribbon stool coming out, but you need to take this piece of bowel out, put in a colostomy, and hopefully reconnect that within the first year. What type of stools would an infant with Hirschsprung's disease have? Ribbon-shaped stools, very good. What is a condition that occurs mainly in children when the intestines telescope into itself? It's usually children that 1 to 3 is the biggest time. Kids come in crying, legs are shaking, they hurt so bad. And it's called intussusception. Put them on a high fiber diet, or we need an air enema or surgery. Those are the 3 treatments. Gastroesophageal reflux disease. What's that? What's that mean? So the stomach flows back up into the esophagus, and it burns and it hurts. And in older children, you'll hear coughing and heartburn going on, abdominal pain. We treat it just like we do adults, or we might have to do that fundal plication, that Nissen fundal plication. IBS involves what? Inflammatory bowel disease. I mean, IBS is mouth to anus, anywhere in between, okay? When you talk about bowel, it's mouth to anus, and it could be anywhere in there that's involved. What would the nurse be looking for when a patient has Meccal Diverticulum? And the diverticulum is that little skin flap that goes inside the bowel, and inside that little skin flap is a blood vessel, and it tears and it rips. So you'll see bleeding, but it doesn't hurt. It doesn't cause abdominal distension because the bleed comes out, it has nothing to do with that, and it doesn't hurt. So all you see is some blood. Twisting of the bowel, blocking of the lumen of the intestines is called I told you these are the things that looks like an appendix, but it isn't. They're a lot less frequent, but they do occur. And it's called a volvulus. And this is a twist on itself, sometimes in a knot, sometimes they're wrapped around different structures, and it doesn't allow stool to flow, and it causes pain just like an appendix does. A school-age child goes to the ER due to abdominal pain and vomiting for the last day. What assessment is your priority to ask next? 6-year-old kids, abdominal pain, vomiting for the last day, 24 hours. What assessment do you need to know now? What's the priority? Tell me about your pain. Where is it? It could be a simple appendix, right? Or maybe it's upper pain. Maybe it's something else. But telling you where the pain is can clue you into what it possibly could be. What would the nurse expect to see in an infant with biliary atresia? So remember, this is biliary liver, has to do with fat digestion. So there's no colors in the stools. If I said malodorous, I think it would have gotten you there quicker. But it's clay colored stools, and then your abdomen goes up because of this inability to absorb fat. What structures of the mouth can be impacted by cleft lip and palate? So it's hard palate, soft palate, and the lip, any part of it. What is the most common associated syndrome for cleft palate? I talked about this syndrome. We talked about dysphagia and the inability to swallow because of tiny little chin, but also they are at high risk for cleft lip and palate. And it's called Pierre Robin because of the inability to swallow. Many of them get a G tube, gastrostomy tube for feedings, and until they can grow out and get older and they can be taught how to swallow and eat with speech. Cleft lip repair is usually done when? And that's about 2 to 3 months. We want to get that sealed because remember, in anything, we always want a child to be able to suck. That's the way that they calm themselves down, stress relievers. When does cleft palate repair typically occur? And that's later, about 8 to 12 months. They have to repair, the upper part of your mouth, like the roof of your mouth. And without that there, they tend to swallow and they can aspirate without their palate there. Goes up, comes out their nose. Esophageal atresia. What's that? So esophageal atresia means that the esophagus has an A without. It does not connect to the stomach. It's there, but it's not connected. What are the classic signs of esophageal atresia and tracheoesophageal fistula? So remember, there's no connection between their stomach, or there's a connection between the trach and the esophagus. What are things you might see? Because we still have secretions in our mouths. We're still swallowing a little bit. So we're going to be seeing that cyanosis, choking, and coughing. When you look at an olive-shaped mass, that is your pyloric stenosis. Remember, your pyloric valve is thickened and it feels like an olive. Neonate suspected tracheoesophageal fistula. Nursing care should include what? So you think that there's a connection between the trachea and the esophagus. So we are going to elevate the head of the bed and we are going to give absolutely nothing by mouth because it goes down to the esophagus and goes right into the lungs, and we don't want that. And we will suction as needed to keep that mouth free and clear of all the extra secretions. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? Epigastric pain, cough, heartburn, abdominal pain. And that's gastroesophageal reflux on the older children. Those are some of the signs that you would see. You even see that in the adult too. Signs and symptoms of hypertrophic pyloric stenosis. Very good. Yes, this is the one that the pyloric stenosis between the low stomach and the small intestines is big and thickened and muscular, and it doesn't allow for food to go down. And it feels like an olive there. Very good. Signs and symptoms of hypertrophic pyloric stenosis is what? And that's, I'm talking about across the room projectile vomiting. It's just not a spit up, it is forceful. Yes. What does the celiac disease affect? And the celiac disease affects the small intestines. Has nothing to do with the large intestines. Well, let's take it back. And why is it that? Well, celiac disease has something to do with nutrition, right? What part of the intestines tries to make sugar, fat, and protein ready for the body? It's all what's secreted from the common bile duct in your liver and your gallbladder and your pancreas, right? So it has to be the small intestines. The large intestine just absorbs all it does. Small intestines takes that food and breaks it down. If you have celiac disease, what should you eliminate from your diet? Wheat, rye, barley. Yes, for sure. Good. A multi-select. Vitamins that children with celiac disease are prone to lose are fat soluble, anything fat, A, D, K, all fat soluble vitamins. These are the ones that they don't absorb, they can't. What foods would you select for a child with a celiac disease? Well, think about what they can't have. I think that's easier to eliminate. They can't have French toast because it's bread. They can't have macaroni and cheese because, again, that's a starch. And garlic bread they can't have. So bacon, omelet, banana, and a glass of milk is perfect. And Kristen's on fire. Phimosis, what does that mean? So when boys are born and they're uncircumcised, sometimes that foreskin becomes extremely tight and you can't pull it down. And when you can't pull it down, can't clean it, the recommendation would be for that to be circumcised. If you can pull it up and down, they're saying there's no problem. But if you can't, it's too tight, you should absolutely get it done, only to prevent urinary tract infections. What is a hydrocele? Hydrocele is fluid around the testes, and it's uncomfortable. And sometimes it actually causes incontinence, even older children and adults. They need an antibiotic. What is cryptorchidism? As you can see, I can't put everything into the PowerPoints, but I'm going to make sure it gets covered. I love the picture of the monkey. So cryptorchidism is when the testicles are not born descended in the sac. We know that a pediatrician, when he is looking at a newborn male, he's going to check to see if both testicles are there. Sometimes they're born up within the abdominal cavity. Now, there's only a certain amount of time they can stay up there because it's too hot. And literally your testicles will die in the heat. So they have to bring them down. Now, what is the best way to test for this and test it so that we know we're getting a proper answer? Are they descended or not? If your room is cold, what happens? They're going to suck up their testicles, right? So make sure your examining room is warm so that the testicles will be down, distended where they should be, okay? You suspect an infant has cryptorchidism. How would you examine the infant? So put them in that warm room. We know they're going to be down where they need to be. Holding them upright is not going to do anything. All we need to do is pull down the diaper and look. As long as it's warm, we'll be able to tell. Are they down or are they up? A hypospadias is the problem with hypo or epispadias is that if you have a parent who practices Jewish religion, they do their bris, the circumcision is done, it's the ceremony. But if you have a hypospadias or epispadias, you need that piece of circumcision skin in order to do a plastic closure. So it becomes an issue, and the parents really need to be told that it's important to save the skin so that they can do this repair. So it's on the bottom or the ventral side of the penis. A multi-select. How is the hypospadias corrected? So we put the foreskin is used to use it. Now we put that stent in, and I actually saw a kid when I was doing clinicals at this PPAC, it's called. It's a prescribed special daycare. It was actually a child with Pierre Robin who also had a hypospadias, and he came in. He was 8 months old. He had the repair. They took the foreskin, closed it, and he had this clear plastic little stent in there, and it was taped to his penis to keep that opening open for it. And just leave the stent there. You don't touch it. Just make sure that it's inside the diaper so it doesn't leak urine everywhere. What is bladder extrophy? It's like a gastroschisis, but it's the bladder. So it's the midline closure. The bladder is left open. And the thing is, the bladder's still working. It's still holding urine. It's still urinating normally. So you put a diaper on them and you keep that area sterile until they could do surgery to get it put back inside of the child. So there's no problem. It's just the bladder's in the wrong place. What are the clinical manifestations of nephrotic syndrome? So it has to do with loss of protein. You don't have protein, you don't have it in your blood, all the fluid goes interstitially and you get swollen everywhere. And of course, you'll have low proteins. Big concern for this child is trying to give this child medicines, because if you don't have protein in the blood, now you have all the free drug in the body, in the blood system. So lower doses, a lot lower doses are needed. Children with nephrotic syndrome are often given with medications for fluid overload. So you're swollen everywhere. This is a concept, pretty high level concept. And we're swollen everywhere. And we need to pull that fluid from the interstitial, put it back in the vasculature and get rid of it. So if we give albumin, which is the protein, and we give a higher dose, let's say at 25%, it will make the fluid on the outside go, oh, we need to go over here now. And it sucks it back into the vasculature. And then we're going to give them some furosemide diuretic and we're going to get rid of it. So yes, albumin and Lasix. And you know that it works because your urinary output will increase, okay? And the swelling will disappear. What is used to treat nephrotic syndrome in children? I mean, besides fluid restrictions and low salt diet and monitoring intake and output and daily weights, we give them the prednisone to try to calm the body down from losing all this protein. What is a priority nursing care of a child with nephrotic syndrome? And we're just going to monitor daily weights, intake, output, right? And of course, we're going to decrease salt and we're going to decrease fluid intake. Very good. Why is erythropoietin used in chronic kidney failure? Where I said, it doesn't matter you're an adult or a child, you are chronically going to be with low hemoglobin, low hematocrits. And then we give erythropoietin because it produces red blood cells and hopefully will decrease the amount of transfusion this child might need. A multi-select. Children with CKD can have renal osteodystrophy. What can this do to the child? Chronic kidney disease, renal osteodystrophy. So renal osteodystrophy is where the bones are not going to be growing the way they should. You see high parathyroid levels, which means too much calcium. Too much calcium can lead to those abnormalities and for their growth to be retarded. So there'll be shorter children also. A diagnostic finding of acute glomerular nephritis may be what? What is acute glomerular nephritis caused by? And it's the positive anti-streptolistin titer, the ASO titer. If you look at ASO, it has strep right in the middle of it, and that's telling you there's strep in the body. Which complication of peritoneal dialysis is most important? Something you're going to watch for? And absolutely, it's going to be worrying about that peritonitis. We don't want that abdomen, which is your kidney at this point, to get infected. We need it to work. What clinical assessment is the most important to report with a child diagnosed with an acute kidney trauma? I had a kid come running around and was playing hide and seek, and he hit the trailer hitch on a trailer, and it was right at the level of his kidney, and he had this huge bruise back there. His potassium was above 6 somewhere, and that was their biggest thing that they were worried about. And of course you worry about, cardiac dysrhythmias. A multi-select. What should the nurse anticipate for a child who just had a renal biopsy? I've had a kidney biopsy. What are you going to monitor? How do we treat them? I mean, I always say it's so close to cardiac cath, the same things. We're going to monitor that dressing for sure. Intake and output, because it's the kidney. We want to make sure they're still urinating, and this child will be in bed for 24 hours. Absolutely not out of bed, because we don't want that kidney to start urinating inside the body or oozing urine on the outside. What would you do if the fluid draining from the peritoneal dialysis had changed color and is now cloudy? So if it's changed color in any way, or you're seeing sediments, this is a telltale sign that peritoneal dialysis has caused some sort of peritonitis, and we need to treat it right away. So call the health cal provider, get that antibiotic right away so we can keep that belly what we need it for. What would the nurse provide to an infant that cannot eat normally? Well, we mentioned a lot of things here. We've had cleft lip, cleft palate. We've talked about esophageal atresia. We've talked about tracheal esophageal fistulas, things where they're not going to eat. How are we going to keep this child happy? And what we're going to do is a non-nutritive sucker, a pacifier that's part of their growth and development. And you're not going to put milk on it. No, we're not. We're not going to do vigorous mouth care. All we're going to do is let them suck on something. And usually it's that pacifier, and it gives them comfort. All right, let's see what we did today. Number 3, an ATM. And Kristen, good job, Kristen. Number 1, Ashley, good job, Ashley. Number 4, Mackenzie and Sean, good job, guys. Could you sign your attendance attestations for me? Make sure you get those done. Anybody have any questions about anything? Tiffany, I've been watching your little girl. She's adorable. She a handful.
Yeah, she is a handful. No.
Yep, that's the age. It's the age. Enjoy. Just enjoy.
Yeah.
All right, guys, you have a good day. Thank you so much. I'll be posting this tomorrow for you.
Thank you.
Take care.
Thank you.
Thank you.
My pleasure.